So do the attendants follow what I have been saying earlier, or shall I revise it?
I think you can continue. Thank you.
Okay, thank you. So sorry actually for the interruption. I was not in a place where I could exactly present it because of the network. So let me continue with what I've been saying. So the other classification is, like I mentioned, according to the force applied by the elastics. So elastics, they could be classified as light, medium, and heavy. And in some books, they classify it as light, and medium heavy, heavy, and extra heavy. So this is basically, like I mentioned, on the amount of force they provide. So in orthodontics, we measure force in ounce, which is a unit of force, and each ounce measures about 28.34 gram force. And the light elastics these are elastics that will provide or deliver a force of 2 ounces, which means about 56.7 gram force. And the medium lights, like 3.5 ounces, the medium heavy, and the heavy. And the extra heavy is 8 ounces and above. So which means we don't use these elastics for the intraoral use. They're basically of extraoral elastic types used with headgears and face masks. So the strength ratio is based on the elastic being stretched 3 times listed diameter. So which means for an elastic to provide this prescribed amount of force, they need to be stretched 3 times of the original size, which means if you have an elastic diameter of 2 millimeter, to deliver a prescribed force by the manufacturer, you need to stretch this elastic to a length of 6 millimeters so that it will deliver a prescribed force by the manufacturer. So the rule of 3 is most of the time empirical. Most of the time we use this elastics. And according to the lumen size, I think you are familiar with 3 by 60, 1 by 8, 1 5 by 60 in the leg. So these are basically the lumen size. How much is the diameter? So the smallest one is 1 by 8 elastic, and the widest one, or largest one, is 3 by 4 elastic. So they have their millimeter interpretation. And the use and clinical implications. The first one I want to discuss with you is elastic ligatures. These are of passive components in orthodontics, and these elastic ligatures of light, medium, heavy thickness may be used for different purposes. Especially those separating elastics are basically used as a space regainers. So we use these separating elastics before fitting of bands, for correction of rotating teeth, for tooth alignment, space if there is any space deficiency, and for canine retraction, for creating space and stabilizing canine, and bring teeth into line of occlusion. So when there is no space, you will use these elastics and create space and bring those displaced teeth into the arch. And the elastomer separators are basically placed in between the interproximal space, so between the 2 teeth, so that they will separate the tight contact of the teeth and create a space. And most of the time we use these separating elastics for band placement. And in the case of minimum space requirement, we can place these elastics earlier, and we can wait for 7 to 10 days. Later on, they will open up space, and we can use that space for aligning and correcting the teeth. And the other thing you have to consider while you're using this separating elastics, they need to be colorful, because sometimes they may be dislodged and lost in the soft tissue, especially in patients with hyperplasia of the gum or the gingiva. We may not find them after a week. So they need to be colorful, but they could easily be identified and removed. So whatever the case, this elastic should not be placed in the interproximal space not more than 10 days, or not 7 to 10 days is enough to create a space. So these are also another kind of usage of elastics. So then the others are elastomeric modules, which we frequently encounter in our clinical practice. And these are still passive components, and they're basically used for keeping the wire in the brackets locked. So they are attaching components. And the elastomeric chain is a kind of active component in the case of frictional mechanics, where you want to retract a tease when you want to close space like diastema and the like. We use this elastomeric chains. So these are of active components. So in orthodontics, the polyurethane elastomeric chains are used extensively as a tooth moving mechanics. And polyurethane chain elastics are commonly used in orthodontics for intra-arch tooth movements, which I said is they are basically movements of single arch, either in the maxilla or in the mandible. So you don't apply them from maxilla to the mandible. So that's why we said intra-arch mechanics. So they are used to generate light continuous force, which we highly recommend in orthodontics. No need to hurry, apply light and continuous force, and so that the teeth will move smoothly with minimal tissue damage. So they are used to generate light continuous force for canine retraction, diastema closure, rotational correction, and sometimes in broadened arch, we use them to constrict the arch. And derotating the tooth with a lingual rotation. So we can use these modules and elastomeric modules as a fulcrum or as a wedge, so that we can correct the tooth which is rotated. So as you see in the screen, we have pictures of placement of these elastic modules in the bracket. So we have wings on the medial and distal side of the bracket. So let's say the tooth in the screen is medially displaced or medially rotated, and you want to have kind of uprightening or correction of this medially rotation. So like we place here the module on the distal wing of the bracket, so that the wire will pass over that distal wing above the module. So a little bit of height difference will be there from the medial wing. So when you tightly ligate the medial wing, there is a sort of wedge effect or fulcrum effect to the medial aspect of the tooth, so that this will correct the rotation. So this is one technique of correcting rotation. And the others are, we have modifications of this type. So that instead of using these modules, we have attached prefabricated weights to be attached on the side, so that we can apply this similar technique for derotating. The others are rubber bands, and these rubber bands were used for the beginning in the orthodontics to transmit force from the upper arch to the lower arch, or in the other way, we use this kind of bands or rubber bands to transmit force from one arch to the other, unlike that of elastomeric chains, which are mainly of intra-arch type. And the other advantage of this elastic is dental crossbites, especially for single tooth crossbites. Simple through the bite elastics are used, sometimes effective for molar in crossbite when both teeth are out of position. These adequate space for them. So when you have a kind of crossbite, especially in the posterior segment involving single tooth, and if you believe that both teeth are at problem, you can adjust these crossbite errors or problems by displacing one against the other using these cross elastics. And the other one is correction of midline discrepancy. And this midline discrepancies, especially in the finishing stage, are problems, especially if you have asymmetric space closure on the side. You may encounter this if you apply force of low force on one side and high force on the other side without measuring using force gauge, and this will result in midline shift. So if the midline shift is minor, is an 2 millimeter in the finishing stage, you can use this diagonal elastics size of 5 by 60 for correcting this midline shift. And sometimes they incorporate class 2 and class 3 elastic on alternately on one and the other side. And the other one, molar correction without extraction. The class 2 elastics produce molar correction, like I mentioned. The very purpose of these elastics is displacing one arch against the other, though most of their effect is dentoalveolar. They bring about some class correction, especially in the case of class 2 and class 3 molar relationship by displacing one arch against the other. They bring about molar correction. So whenever you are sure that this is basically of a dental problem, you can use this elastics, and you can adjust the problem. When this pattern of movement is desired, the amount of force varies with the amount of tipping allowed in the manual arch. So with a well-fitting rectangular wire in the lower arch that is somewhat constricted posteriorly to prevent rolling of the lower and springs, they have some unwanted side extrusion or supply occlusion of the incisors. You can also use these elastics to bring. We have the cross-palatal elastics, and we have the diagonal elastic, which we have been discussing earlier. So in the case of zigzag elastics, these are basically used in the finishing stage to bring about class correction. So once you have done all the tasks prior to this, in the settling and finishing phase, you can use this zigzag elastics to bring about class 1 molar relationship. And the crossbite elastics, like I mentioned, they are mainly used for correcting single tooth crossbite when both the tooths are displaced one against the other. I think you can correct these problems. So the recommended force for using crossbite elastics or through the bite elastics is about 5 to 7 O's, which is in between medium and heavy force. But this will bring about correction. In the cross-palatal elastics, like I mentioned, in the case of broadened and buccally displaced dentition, you can use this cross-palatal elastics to bring about this into the palatal side. Diagonal elastics mainly used for the correction of midline shift, and the force amount is in a range of 1.5 to 2.5 O's, which is a kind of light force. And the other one is the open bite elastics. This is for correction of an open bite, and it can be carried out by using a vertical, triangular, or box elastic. So, like you all understand, when you say open bite, it's a vertical discrepancy or discrepancy along the vertical plane. So you can use the different pattern or arrangement of elastics, either triangular, or the vertical or box, to bring about changes in this kind of problems like open bites. So the recommended size of elastics for correction of open bites using box elastics is the lumen size should be about 1/4 or 1/4 inch, and the recommended force dose is about 6 O's, which means heavy force is required. And the triangular elastics are mainly used to bring about class 1 canine relationships. They are like of smaller size. The stretching should not be that much larger, and the recommended force dose is in the case of medium force, which is about 3.5 O's. So this is what we mean by box elastics, and these are also box elastics in the lateral segment, and this is what we mean by the triangular elastic, which is about 1/8. And the vertical elastics, or the spaghetti, these are actually kind of elastics to bring about settling in the posterior segment. So to bring about the correct bite you use this spaghetti kind of arrangement. So the force used is about 3.5 force. And the M and W elastics force used in the range of 2 O's, and the recommended elastic size is about 3x4 inch, which means the largest elastic size. And as you can see in this picture, we have different kinds of arrangements. That's why the name is given M and W elastic. So if you see from the molar aspect, this is a kind of arrangement of M shape, or the configuration looks like M with tail. It comes like this, go down, up, and here, and in this with the tail. So this is kind of M with tail. And if you put the arrangement from the canine aspect, it's actually W, right? It comes down, up, and go, and down, and finally with tail. So we have arrangements of different types: W with tail, M with tail, and the like. And the lingual elastics, this can be used as a supplement or a counterbalance agent to buccal elastic force. So we can use this lingual elastics for two purposes. One, when we use coupling force to bring about rotational change, you use same and equal and opposite force to bring about this effect. So you use this force, one on the buccal side and the other on the lingual side. This is one way of counterbalancing the effect when you say counterbalance. And to augment or potentiate the force on the buccal side means when you use the retraction, especially in canine retraction or in group retraction, you can potentiate the buccal force by incorporating the lingual force or the lingual elastics. So this will give you additional components so that force will be applied both on the buccal and on the lingual side. So this will benefit to have an even force distribution both on the buccal and the lingual side. So saying this, what is the advantage of elastics? Why we frequently use this elastics in our orthodontic practice? So the first advantage is they are very inexpensive, relatively hygienic, and they are easily applied. If you have a basic knowledge, you don't have problem applying it. And the placement and removal for the elastics requires a very little chair time. And the materials are relatively biocompatible to the mucosa and to the soft tissue intraoral, unless patients are allergic to those latex wrappers. And the major useful property of this natural latex wrapper is still resilience, which means after a substantial force is applied, they have a capacity to return to their original shape before they are plastically deformed. So this will be used as a source of continuous force in our orthodontic practice. So this property makes useful intraoral for the appliance of tractive force in a range of up to 6 to 8 ounces of force. So basically, the recommended force dose for intraoral use should not exceed not more than 6.5 O's. Actually, 8 O's is for most of the time, 8 to 14 O's is for extraoral use to bring about skeletal effect. And the disadvantage, like any other instrument or any other material, when extended and exposed to an oral environment, they absorb water and saliva. So this is mainly due to the absorption of water and saliva into the matrix of this polyurethane chain. So they result in permanent stain and suffer a breakdown of intraoral bond that leads to permanent deformation. That's why most of the elastics, they have a quick decay rate. They usually dissipate most of their forces, about half of their forces during the first day of the application. So the remaining force will proceed for the subsequent weeks. So that's their main problem. So they don't constantly deliver the initial force. They gradually decline, and the greatest force loss occurs in the first day and the first 3 hours. So they also experience a rapid loss of force due to the stress relaxation, which is in the basic constituent of the polyurethane chain. and resulting gradual loss of effectiveness. So the loss of force makes it difficult for the orthodontist to determine the actual force transferred to the dentition. So even if you are using force gauge in the initial application, after subsequent days, you don't exactly know how much force is being transmitted to the dentition. So you cannot estimate the amount of movement performance because of their force loss. And the force delivery and force degradation is a very important thing we have to discuss. So different scholars in orthodontics discuss different things. So a guy called Wagon stated that latex elastics are a source of continuous orthodontic force because they are continuously placed in the dentition. Though the force is declining, still they are providing uninterrupted force. So we can say that these forces are source of continuous orthodontic force. This is an assumption made by Wagon. And another guy, Bati, conclude that one characteristic of this elastomic chain is inability to deliver continuous force level over an extended period of time. So he believed that we cannot mention these elastics as a source of continuous force. And a very genius guy called William Profit, he is a renowned orthodontist in contemporary orthodontics, stated that it is simply must be kept in mind that when elastomers are used, the force decay rapidly, and so can be characterized as uninterrupted rather than continuous force. So he believed that because there is a decline in the amount of force delivered initially, we cannot say these elastics are the source of continuous force. Rather, it's a kind of uninterrupted or interrupted force system. So these are different scholars based on their assumption. So basically, we can have a side for one of the guys, but still this is in doubt. So let's come to the elastic chain, which is the active component of frictional mechanics and a source of force for retracting canine and for also group retraction and also for diastema closure and spaces among teeth. So the initial force, like I said, force decay of 50 to 70% occurred in the first 24 hours. And of that 24 hours, the first 3 hours are critical. And after that, the force degradation is more or less smooth. It means it continues in a steady manner. And after the first day, the force degradation declined in the relatively stable manner. And I think you're familiar with the terms long chain, short chain, and continuous chain. So when you say long, continuous, and short, it's basically we are referring to the inter-ring distance. How much are the rings separated? So the measurement is usually made from the first ring to the other ring, and that distance will tell you whether that chain is long, continuous, or short. So the inter-ring distance for the long chain is around 4 millimeters. So the gap between two rings is about 4 millimeters. And the inter-ring distance for those short is between 3.5 millimeter, and the inter-ring distance for the closed loop or the continuous ones is about 2.8 millimeter. So this is what we mean by. So there is a longer distance or gap between two rings for the long chains, and very close difference or gap for the continuous ones. So the filament shape of chains is another characteristic. So we say long filamentous, short filamentous, and closed loop ones. So the Genova et al. Show that the short filamentous chains generally provide a high initial force levels and retain high percentage of remaining force than the long filamentous chains. So comparing these three kinds of chains, those chains with the long inter-ring distance, they provide lighter force, or also they become decayed very, very fast compared to the closed loop ones or the continuous ones. So the longer filamentous chains will deliver a lower initial force at the same time and exhibit greater force rate of force decay under load than the closed loop ones. So Rocky recommended extending chains, which means extending means pre-stretching. Extending chains to 57% of their original lengths to provide the desired force of approximately 300 to 250 grams of force. So you have to deliver a force of 250 to 300 grams of force with chains to bring about space closure and retraction. So the elastic chain which you have been using should be pre-stretched about half or 75% of its original size to deliver this amount of force. So in general, most force decay occur at the first hour, and the greater initial force, the greater the force decay of all chains. So if the force delivered by the chain is greater initially, which means greater force decay will also occur earlier. And the other one is those intramaxillary elastics. So these elastics are most frequently used auxiliary force delivery system used in modern day orthodontics, and they provide the cheapest and relatively reliable force delivery. So stretching the rubber elastics of 7 millimeter diameter into 20 millimeter lengths or deliver or exert a force, which means if you have an elastic size or diameter of 7 millimeter chain, elastic, and if you stretch it to a length of 20 millimeter, which means when you use it from the maxilla to the mandible or reverse way, it will give you a force of 160 grams. And if you stretch similar, give you about a force of 243 millimeter, it will give you 350 grams force. So the more you stretch, the more force it will deliver, it means. So most of the relaxation was shown again for this elastics during the first 3 to 5 hours. And from that time onward, the declination is steady in a more constant way. So the study has been done regarding this different size of elastics and amount of stretching and the amount of force they deliver. So in a study to evaluate the latex elastic band fatigability of 3 band size, most commonly 3 by 60, 1 by 4, and 5 by 60. So these are the different lumen size of elastics. So these guys, they stretch to the length of 30 millimeter and 35 millimeter. So they try to compare the amount of force delivered by these 3 different types of elastics with these 2 different stretching lengths. So let's see the first one, and you will compare the remaining from the table. So the first one is 3 by 60 elastic. This is the commonly used elastics for correction of class 2 and class 3 molar relationships. So if you stretch 3 by 60 elastics for 30 to the length of 30 millimeter, it will deliver a force of 320 grams. And if you stretch same elastic to the length of 35 millimeter, it will deliver a force of 350 grams. So which means the more stretching you give for the elastics, the more force you will receive. And the other thing is what you have to compare is the force component along the vertical and horizontal aspect. Because when you stretch elastics, you don't only receive vertical force or horizontal force. You have both horizontal and vertical force. So the distal driving force component is about 95.7% and 70% of the elastic force with the mouth closed while you opened respectively. So they compare again the amount of force delivered by elastics when the mouth is closed and when the mouth is opened. So more force means more force will be delivered along the horizontal aspect if the patient closes his mouth. That's why guys like Ofnium recommended using elastics in nighttime, and so that patient will stay closed and the amount of force on the horizontal aspect will increase. So they compare this force amount in closed mouth and open mouth. So in closed mouth, the amount of force delivered by the elastic is about 97.5, which is quite great. And when the mouth is widely opened, the amount of force delivered by the elastic will be 75%, which means as you open the mouth, especially in daytime, you have functions. So the amount of force delivered by the elastic will decline. So that's why most of the orthodontists recommend using this intraoral elastics, especially those class elastics, to be used in nighttime. This is due to the factor that the obliquity of the elastic will minimize, and this will increase the force component along the horizontal aspect. And coming to the chain, two guys called Young and Cedric, they recommended initial extension of chain by 57% of the original length to provide an optimal force level. So pre-stretching is recommended. When you pre-stretch the elastics, you are trying to avoid stress relaxation in the elastic, so that the force decay rate will gradually decline. So Wagon recommended pre-stretching the elastic chains third of the original lengths to pre-stress the molecular polymer bonds in improving strains. So this will prevent further force decay in the meantime. And elastics, like mentioned, the rule of three means to obtain the prescribed force by the manufacturer, which is mentioned on the package of the elastic. You have to stretch the elastic 3 times of its original width, but it will deliver the amount of force prescribed by the manufacturer. So analysis of elastic forces, these intramaxillary elastics used in the single arch, like class 1 elastics, from canine to first permanent molar, or from 2 points on the same arch, are used between 2 points in the same dental arch. So these are mainly class 1 elastics. In the intermaxillary elastics of class 2 or class 3. So intermaxillary elastics are used between maxillary and mandibular dental arches, and often you can use of this intermaxillary rubber dam elastics to be worn at night, like for the reasons I mentioned earlier. And a guy called Ben analyzed elastic force for under various conditions, and he found intermaxillary strengths of 4 O's when mouth is closed, shows distal driving force of 3.59 O's and loss of 2.5%, which means if you apply an elastic extending from maxilla to the mandible or mandible to the maxilla, which is class elastic, to deliver 4 O's, if the patient applies this elastic in closed mouth, the force loss will only be about 2.5%. But if the same elastic force is used in open mouth, the amount of force loss due to the mouth opened will increase to 25%. So that's why Ofanium advocates using elastics in closed mouth, and he believed that nighttime is a good time because most of the patients or the guys will be out of function, and tongue and the mouth will be at rest. So there will not be mouth opening, so more force will be received. They will not be forced to lose. And when heat gears is used with elastics parallel to the maxillary arch, even the amount of force loss will go to 0. There will not be any force loss. Coming to class 2 intermaxillary traction force from the distal of the mandibular first molar to the medial of the maxillary first molar, that's in horizontal vector of 96% and vertical vector of 27%. So in situations where 4 premolars have been extracted and the space is closed, the amount of stretching will decline. So the same class 2 elastics now stretched over a shorter span and has horizontal vector of 93%. So the concept here is, if you want to have a higher horizontal force component, you need to extend the elastic to the farthest distal point, which means, let's say you have first molar and second molar. So if you apply elastic from the medial of the canine, in the case of class 2 elastic, to the second molar hook, you will have more horizontal force vector. So the vertical force vector will be minimized, so that you can have this class correction very easily. And in this example, all the premolars have been extracted and space is closed. And if the guy wants to apply, he believes that there is a remaining class correction, and he applied class 2 elastics. So he stretched it to a shorter span. So the horizontal force vector declines from that of 96% to 93%. So this is what's meant by the implication. On the other hand, class 2 elastics that are stretched over a long distance from distal of mandibular second molar to the medial maxilla can have horizontal effect of 90%, similar vectors of 2%. So still extending to the farthest point will give you more horizontal force component. To get the greatest distal effect of class 2 elastics with the smaller collateral vertical vector, elastic should be applied from the farthest distal point, that is the distal of the mandibular second molar to the medial of the canine, which means you can use some power arms in frictional mechanics, and you can stretch that using this power arm. So when we use these elastics, what sort of changes we expect in the course of the treatment? So changes induced by intramaxillary elastic forces are the following. So the emerging maxillary incisors might be there, and mandibular molars, because the forces applied from the two point of attachment. We expect the change in the anterior maxillary incisors and in the posterior molar segment, mandibular molar segment, and tipping of the occlusal plane downward anterior. As the teeth elongate because of the traction in the anterior segment, you will expect the occlusal plane to tilt downward anteriorly and upward posteriorly. And similar effect will happen in the mandible, and the lower incisors also will tip labial. As the molars extrude due to the traction force by the elastic, it will bring the occlusal plane down anteriorly for the mandibular segment, up posteriorly for the mandibular segment, which will bring the mandibular incisors to more labially tipping position. Then pressure is exerted on incisors in the vertical direction, so bringing them into supraocclusion. So they may increase in length after usage of this class 2 elastic. So that's why we have to be careful of the incisor display while we are applying these elastics. And tilting of anchoritis may occur. So we expect some medial in rotation of the molars in the mandibular molars, especially in the case of class 2 elastics, and also medial in rotation of the maxillary molars, especially in class 3 elastics. So many of these secondary effects of intramaxillary tractions may be reduced by minimizing or optimizing the amount of force we are using with elastics, whereas incorporating a more heavier wire than using lighter wires, because when you use lighter wires, they will have effect of deflection. So that deflection will result in some sort of unwanted tooth movement. So you may need to incorporate like a high pull headgear to prevent the supraocclusion of incisors in the case of maxilla, and you may incorporate some torque within the arch wire to prevent this labial tipping in the maxillary incisors. So there are different factors that will affect the elastic chains. So color, fluoride, air, ozone, disinfection, sterilization, thermocycle, pH, mastication, daily diet, staining, oral cavity, and water. So I think we may clarify in the answering question session, but these different factors have different effects. So if you look at the fluoride component, there are chains called fluoride containing chains, and we have the standard or the conventional gray chain. So when we compare these two kinds of chains, these fluoride containing chains, they have advantage of releasing fluoride, so preventing the process of demineralization and enhancing remineralization in the process. But they have problem of rapid force decay. So they conducted the research comparing this standard gray chain with this fluoride containing chain, and the amount of force decay by the fluoride chain after a week was not enough to bring about the desired movement. So initially, this fluoride chain was delivering about 280 grams of force. That of gray chain was providing about 308 grams of force. And after a week, the fluoride containing chain almost remains with a force of 43 grams, which is undesirable and quite inefficient even to bring canine retraction. And the standard gray chain was having remaining about force of 107 grams, so which is still enough to bring about canine retraction. So they have rapid force decay compared to the standard gray chain. And the air, when the chains stayed for a longer time in the air, they will expose themselves. So the polyurethane chain or the unsaturated double bond chain in the basic molecular level will be disintegrated. So they will be very fragile. And pH similar. Those patients with a acidic pH will have reduced force decay rate. In those patients who have basic pH, we have high force decay while using this. Staining, we have different kinds of foodstuffs we use in our daily life, and some of the foods we take will result in a rapid staining, and the others will no longer bring any staining. So coffee is considered as among the rapid staining food item, and those colorless foodstuffs and Coca-Cola are considered to be less staining or reduced staining. And there's some food items like wine juice, tomato ketchup, and the like, they will bring about gradual staining. So anyways, when you talk about staining and swelling, it's mainly associated with the accumulation of bacterial debris and water in the matrix band or in the matrix of the chain. So that will result in disintegration, and that will result in the sort of staining and swelling. So it's mainly associated with a disintegration of the molecular bond. So the others also have more or less similar effects. So far we have been discussing different things about the elastics, and now we come to another intraoral auxiliaries, which we call springs. So we have different kinds of springs. We have uprighting spring to uprighten the tilted toes. We have rotating spring to bring about rotational change, torquing spring to bring about torque effect, and then open coil springs like to open or maintain or regain space in case of space deficiency or when space is lost. And we have also closed coil springs, which will bring about space closure. So open coil springs will create space, and closed coil springs will bring about space closure. So they can be made from different kinds of material, mainly of stainless steel and nickel titanium. So the force exerted by the springs is directly proportional to the diameter of the constant wire and also the modulus of elasticity of the material. So when you say modulus of elasticity of material from a dental material course, it means we're talking about the stress and strain ratio, the amount of force applied per unit area, and for how much displacement per unit length will happen when you apply. So as you all know, stainless steel is with a high modulus of elasticity and the like. The comparison of certain properties of nickel titanium and stainless steel coil springs. So when we compare the nickel titanium, these are low and constant force. They provide low and constant force. They are expensive, clinically effective, tend to fracture between eyelet and spring. So there is an attachment of the coil spring with an eyelet. So the eyelet will be used as an attaching component of to the hooks in the buccal dewar in the canine, and more frequently used. So this nickel titanium type of coil springs are mainly used nowadays, and stainless steel are most of the time outdated, and they are high initial force. They provide high initial force. They are relatively cheap, clinically effective, more or less effective, like communicated tiny ones, and more resistant to fracture. And the cheaper option, but less range of action, has led to this decreased use, so that they're not currently in use. So in the open coil springs, I will not go into details because with the side and the leg, but we have to discuss about the clinical aspect. So we have open coil springs of different size, and based on the amount of force they deliver, we can classify them as light, medium, and heavy. So if the amount of force may range from 50 to 200 grams. So these coils are made up of 0.01 inch, 10 inch wire to lumen of 0.65 inch. The open coil springs are usually compressed to the third of its initial effective length. So when you use open coil springs to gain space, you don't simply cut and insert between teeth. You have to measure, and you have to also determine the amount of compression, because always in coil springs, especially in open coil springs, it is the deactivation force that will open the space, not the activation force. It means the activation force is compression force, but the decompression force will bring about the space opening. So when you compress the open coil between two teeth to bring about space, you need to have an optimum length or size. So the recommendation is like here, third of its length, or clinically explaining, you have to add, let's say, the distance between two brackets is about 5 millimeter, and you want to open up a space of 6 millimeter or 7. So you have to go gradually. So in the first application, you need to have an additional length of 2 to 3 millimeters, which means in space of 5 millimeter, you have to compress 8 millimeter lengths of open coil spring, so that those 2 to 3 millimeter compression will bring about space opening. So you don't apply a very larger size coil spring so that it will bring some rotational change. Always it should be within the limit. So some scholars or some authors recommended add the width of the bracket into the distance between two brackets. So that's quite enough to bring a gradual space opening without or with minimal rotational change. In the closed coil springs, like we mentioned, we have different sizes of 6 millimeter, 9 and 12 millimeter, and sometimes also 50 millimeters. So these are also similarly, they can be used for canine retraction as well as for in-mass retraction, especially in frictional mechanics. So the closed coil springs are basically providing force ranging from 50 to 200 grams. So the spring's effective initial length is 3 millimeters. The springs are activated to the length of 50 millimeter or 5 times the initial length. So especially in the case of in the selection of appropriate size of this closed coil spring, what matters is the space between the extraction area or extraction side and the amount of space contained. So the amount of stretching will depend on the amount of space or gap between the anchor unit and the teeth to be retracted. So you can use 6 millimeter coil spring size, 9 millimeter, or more than that, depending on the amount of space available. And uprighting springs, these are mainly used for to bring about rotational changes. So these are basically the uprighting springs. So this will bring about clockwise type of rotation, and this is these are basically rotational springs. An uprighting springs is just when the teeth is tilted either palatally or bacally, it will bring about uprighting effect in the tooth. And rotational springs to bring rotation either in the mesial or distal direction or clockwise or counterclockwise direction. And the one you see in this picture is called Goodman spring. It's basically torquing spring. So to bring about positive or negative root torque for individual tools. So it will bring about individual root torque. So it's basically constructed from 12-inch or 0.02 or 0.014-inch Australian wire squeezed between teeth, and so you can manufacture it in chest side, or they're also available in the market. They're prefabricated. So these are called Goodman spring. So the transpalatal bar, or TPA, is an invention or an innovation by Robert Goshgreen in 1972, and spans palatal between the upper first molars with an omega loop in midline, and is effective as an anchorage maintenance device as well as an active alternative. So it could be passive component or an active component. So when you say passive component, it doesn't deliver a force to the dentition or group of teeth. It simply maintains the tooth in their place. That's passive usage. And when you say an active component, they provide either expansion force or constriction force. So that's why we could use it as either active component or passive component in dental. So TPAs can be used for molar stabilization and anchorage correction, especially in along. When you say anchorage not only reserved only in the sagittal or anterior posterior direction. We should protect the anchor unit both vertically, transversely, and also anterior posterior. So this TPA mainly provides anchorage preservation or anchorage control both in the vertical direction as well as in the transverse direction. And also molar stabilization also for torquing the molars. So when we incorporate some twisting in the TPA, you can also provide some torquing effect in the molars and rotation. So they can be fixed or removable. So when you say fixed, you don't remove them or insert them. Once they are soldered into the component, into the molar band, they are there always. When you say removable, if a patient doesn't feel comfortable, you can either change it by yourself, or the patient can just remove it. So that's what you say when you say removable and fixed. So the removable ones are usually attached to the lingual sheath with a module or with the ligature tie, and the fixed one is soldered to the molar. So the remote TPA is fabricated in from 0.02-inch round wire or 0.06 TMA or Ilgoli wire, and the midline omega loop is usually oriented distally with 1 to 1 clearance in the palate. So in order to avoid soft tissue impingement on the palatal soft tissue, when you construct this omega loop, it should be a bit further from the palatal soft tissue. So the clearance usually ranges between 1 to 1.5 millimeter, and omega loop could be oriented distally or mesial, which means it could face mesially or could be distally based on the need and the indications. So the horizontal anchorage, when you say horizontal anchorage, we mean transverse anchorage. The transpalatal have been claimed to provide horizontal anchorage of approximately 1 millimeter per year. So this is an estimation made by a scholar or a guy called Rule, and he mentioned that if you apply a transpalatal bar to the anchor unit, you could prevent the horizontal constriction or anchorage loss of 1 millimeter per year on the site of application. So this is what we mean by horizontal anchorage. Vertical control of upper molars by placing the bar 5 to 6 meters off the palatal mucosa with a large mesial facing loop. So, like I said, the face could face mesially or distally, which means mesial to the first molar or distal to the first molar. So, when you believe we need to prevent further extrusion of molars, maxillary molars, you could place this TPA with a loop facing mesial and with a clearance of 5 to 6 millimeters, which means this will bring a more closer approach to the tongue. So when the tongue frequently touches, there will be frequently applied force, so it will prevent the further extrusion of the molars at the site. So that is what we mean by control of the anchorage along the vertical plane. So there is no evidence to support this, although the transpalatal bar probably helps to prevent development of anterior open bite by torquing the roots of the upper molars backally. So some scholars don't believe that this doesn't bring about change in the vertical plane, but rather it will bring some extrusion of the molars by bringing some buccal tipping of maxillary molars. So that's why the open bite is prevented. Otherwise, it doesn't have any component or force component on the vertical uh, aspect. But this is still ambiguous. But still, we can apply that way. The rotational control of upper first molar. So guys called Laman and Holmes have shown that the medial rotation of upper first molar is present in many class 2 cases. So when you use elastics and also chain in the case of space closure after the extraction of the first premolars, the most frequent encounter is medial in rotation of the molars. So to prevent this, we could incorporate some derotational effect by incorporating lingual transpalatal bar. So the derotation of molar may be produced by 1 centimeter of arch length gains as first molars rotate about their palatal roots. So as you all know, derotating the posterior toes will give us a space, and derotating the anterior teeth requires a space. So that's why when you derotate a medially in or medially rotated molar, you could have some sort of molar correction, as well as you could gain space of 1 to 2 millimeters. So this is because the discrepancy or the difference in the mesodistal and macrolingual widths of molars. So thus, we can incorporate transpalatal bar to prevent this medial rotation of molars in the case of retraction. This transpalatal arch may be used to gain arch lengths and to help to correct class 2 molar relationships, like I said, by bringing preventing medial rotation and torque control of upper molars. So the transpalatal can be used to produce effective buccal root torque of upper first molars. So they will bring about some buccal root torque. By giving that, we can prevent some effects. So on the upper arch expansion, smaller amounts of upper arch expansion up to millimeter or so can be obtained with transpalatal bar. So this means by applying some pushing effect from the lingual aspect, you could receive some transverse expansion in the arch. So it's not promising, but still you could have a 1 millimeter expansion using this TPA. It's a kind of slow expansion. Most of the changes are dental behavior. In Gravel, they have described the use of statically determined transpalatal bar to correct unilateral crossbites. So in the case of unilateral crossbite correction using TPA, which means you will use one segment as an anchor unit and you'll apply force to toes in crossbite. So all the segment in one side will have a kind of pushing effect to the toes in crossbite. So this will bring about change in the transverse correction. So that's why this guy mentioned this technique to bring about change. So this is what we mean by facing loop medially and facing loop distally. So this forward facing loop or facing loop in the medial direction allows transpalatal bar to be placed both in the upper, also in the upper first and second molar areas. Because if you use this distally facing loop, the second molar, you may have patients with high tendency of gag reflex. So when they come in contact with the distal aspect of the loop, they may have frequent gagging. So that's why this partially or medially facing loop could be used both in the first and second molar without any problem. And the Nancy palatal arch is a modification of palatal TPA or transpalatal bar. So here, as you can see, we have an acrylic component which is attached to the anterior segment. So the force will be received by this palatal valve. So the tooth will receive force from this palatal valve, So it will transmit to the molars. So the molars will get no chance of drifting mesial. So they usually use this technique to prevent anterior posterior anchorage loss in the case of space closure, in the case of canine retraction and the like. So in this case, you could have prevent the mesial drifting of the molars by receiving force from the palatal path. So care has to be given for patients with acrylic allergy, and also how the acrylic button should be attached to the palatal soft tissue. It should not be tightly attached so that it will impinge the soft tissue. The quad helix is a kind of appearance. It's again used for slow expansion. Many the changes are skeletal in dental alveolar, but sometimes it could bring about some skeletal changes in young children with remaining sutural closure. So the mode of activation, as you can see, is indifferent. You have point one activation in the anterior segment. So when you compress using 3-point player in this segment, you could have expansion of the sides. So it will bring about some transverse expansion. When you make activation at point 2, you could receive some sort of expansion in the premolar and canine region. So this is how we expand transversely in the case of young patients and also in the patients to bring about some buccal tipping. So most of the effects are dental. So these are the different wide size for using quad helix. So the lingual arch, we could have a lingual arch for the maxilla as well as for the mandible. So when you say lingual arch for the maxilla and lingual arch for the mandible, as you can see, the arrangement is a bit different because there is a tongue in the mandible. Most of the time, the arrangement of the lingual arch is of horseshoe shape, and in the case of maxilla, because tongue is nowhere or there is no interference from the tongue, the arrangement is more bar type. But both are lingual arch. So the lingual arch can be used by itself or inserted into the complement as a labial appearance. So sometimes we could use this lingual arch as a space maintainer in the case of young pediatric patients when there is bilateral premature space loss. We could use this lingual arch as a means of maintaining space, especially in the case of preventive and interceptive orthodontics. We use this lingual arch as a space maintainer, bilateral space maintainer. Let's say you have prematurely lost primary second molar, so you have erupting first permanent molar. So if you want to maintain a space for the coming permanent molar, you may keep this space by using this lingual arch in place. And sometimes, like I said, it could be used solely, or it could be in combination with a buccal aspect, with a buccal component. So when you say to complement the labial appearance, if you don't want any further constriction or any further displacement of teeth to the lingual side, you may use as complement for the buccal, for the labial appearance. So the low lingual arches are valuable where space is critical for lower central line correction. So we could use this alternatively. So most of the time, the very basic advantage of this lingual arch in the mandible is maintaining the mandibular arch perimeter. As you can see, the arrangement is more or less following the arch form, so that we don't expect further loss or change in the arch perimeter if you have this lingual arch as long as possible. So the study has small group used lower lingual arch made of 0.32 inch or 0.07 stainless steel, which contacted the cingulum of the lower incisors. In the experimental group, lower molar stayed more uprightened, and lower incisors procklined. So in those groups where these lingual arches were used, we found a more preserved arch perimeter for the mandible. So the incisors were procklined and the molar stayed more upright. So there was no any drifting or tilting of in the molar segment. And the total arch length stayed constant, whereas in the control group it decreased by 2.5 millimeters. So in those control groups where we don't use the lingual arch, we found out an arch loss of 0.25 millimeter. So we could have different attachments for these lingual arches. So the passive application of this lingual arch can be securely soldered to the bands, like in this case with the lingual sheath, or they have also precision fit buttons or brackets which are attached lingually. So there's also a hinge and cap brackets like this one. So like in self-ligating brackets, you insert the wire and you will lock it. So the lingual arch will be safely placed in the area. In lingual arch configurations, like you see in this picture, two designs are there: transpalatal arch type A and the horseshoe shape. So horseshoe shape basically for the mandible, and this type A is most of the time for the maxilla. So although type A is usually inserted from the medial of the hinge cap, like you see in this case, we could also insert it from the distal aspect. Sometimes the two inserted from the distal. So this can be avoided in pigment of torus palatinus or lingual position second premolar. So in the case of the prominent if there is prominent torus palatinus, or if you have a lingually placed second premolar, rather than inserting from a medial aspect, it's better to insert it in such a way from the distal aspect. So it will avoid contact of this tora. And let me continue with what I've been saying. So because of the tongue and the mandibular lingual arch must have the horseshoe shape configuration due to the tongue placement, and two types are commonly used. So the high mandibular lingual arch, so touches the entire cingulum, like you see here in this picture. So it should take that bulginess on the lingual aspect of the incisors and used for space maintenance or for other disease anchorage. So if you don't want the incisors to displace lingually, and if you want to keep that in place, you can use this kind of attachment, the high mandibular lingual arch touching the cingulum of the mandible. So this will prevent the lingual timping of the mandibular incisors. So it can also be used to prevent the mandibular incisors from tipping lingually in extraction therapy. So the most common field complication of group retraction in case of extraction case is tipping of thesis or damping of the incisors, both maxillary mandibular in the palatal or in the lingual direction. So we can use this kind of lingual arch to prevent further lingual tipping of the incisors. And the low mandibular lingual arch, like you see in this picture, it should be fabricated as far as possible so that the tongue will not exert any vertical or forward force on it. So it's the low position has the added advantage of smooth curvature that is easy to fabricate and fit because of counter around the irregularities is not required. So in this case, we don't expect the lingual arch to touch the lingual aspect of the dentition, which are mother-lined. So it's basically lowly attached. It is around the cervical portion of the teeth. So we don't want to incorporate this. So we have different wide sizes for incorporating this kind of lingual arches. And the passive application is it doesn't apply any force to the tooth component, rather it keeps what is in place. So here in this picture, an important function of passive lingual arch is to stabilize the posterior teeth together as unit and to maintain arch width and form. So it's basically to prevent arch perimeter loss and also to keep the teeth in place. Full-size stainless steel wire is used for this case, and one of the simplest application would be space maintenance. So like I mentioned, in premature loss, especially in case of bilateral space loss, you can use this passive type of lingual arch to maintain the lost space and to prevent the mesial drifting of posterior denture. So a lingual arch can also prevent side effects during space closure. So as you can see in these two pictures, we have a kind of application of lingual arches to prevent these unwanted side effects. So look at the first case where retraction has been done. And as you can see, there is a mesial rotation of the molars due to the retraction force. So it could not be prevented because of there is no lingual arch placed. So in the second case, where you have the lingual arch, you don't see these changes, and only the changes are in the vertical direction and anterior posterior. So there is no mesial rotation of the molars from the retraction force. So this also used to prevent such kind of unwanted side effects during the retraction phase. And a passive lingual arch can also serve as a rigid base structure for attachment of auxiliary springs and elastics. So as you can see, these two cases, one case we have a fairly backally positioned canine. So they incorporate the elastic chain with a passive lingual arch application. So there is a soldered hook on the lingual arch. So there is an extended chain which will exert force from this passive lingual arch to the displaced canine. So using such kind of mechanics will prevent the unwanted side effects of the adjacent teeth. So this lingual arch will receive a strong anchorage unit of force from bilateral side of the molars and also from both segments. So we don't expect displacement of the premolars and the canines. Only the dentition or tooth which is out of the arch, the canine will come in place without any further displacement of the adjacent teeth. So as you can see here also, they are applying a similar technique for displaced canine to bring into the arch. So this is also another passive application. So there is no force applied by the lingual arch to the displaced tooth, rather it is used as only a strong attachment unit. And the lingual arch also offers many creative possibilities in the conventional orthodontics. As you can see in this picture, they have used the soldered finger spring to the passive lingual arch. So you can see here there is a lingual displaced central incisor. So they have a passive lingual arch. They soldered this finger spring to the passive lingual arch. So there is a continuously applied force from the finger spring to that of the displaced lingual displaced central incisor, so that it will come in place without any further displacement of adjacent teeth because of a strong anchorage received bilaterally from two molars. So the teeth is well in place, but no displacement of the adjacent teeth. Patient with bilateral maxillary second molar buccal crossbite, as you can see here, the dentition at fault is not 6, it is rather 7, which is out of the arch. So if you use labial technique or biomechanics, what you have to do is you will bond 7 and you will pass wire from 6 to 7. So in bringing this into the arch, which means more palatally, you will have a chance of displacing the maxillary, the two molars buccally. so which you don't want in this case. So the very good advantage of this lingual arch, as you can see here, that the two molars are served as a unit. So there is an extended chain from this passive lingual arch to the buccally displaced second molar. So without displacing this, because this will serve as a single unit to bring this into the arch. So without any problem, this is come into alignment. Also, this is one way of correcting buccally displaced molars. In active applications, the lingual arch passive shape can be modified to deliver a force which will bring the teeth into alignment. So in this active application, you have to do some modifications, some bendings in the actual lingual arch. So the appliance can be useful in delivering both symmetric and asymmetric force system. So you can provide a symmetric force system. It's uniform force, goes right and left side or bilaterally, or you can use asymmetric force to bring change in one segment only. So a symmetric application, when we say symmetric application, in the case of bilateral expansion, you will have a bilateral equal forces which will bring transverse expansion. So you don't want the one side to be expanded and the other side to remain in place. So in such cases, you can use bilateral expansion. It's a kind of symmetric force application. So molar and processing start with modifications require reciprocal anchorage and hence is logical application of lingual arch. So the bilateral expansion requires two single forces acting buccally at the lingual bracket. So by modifying the shape of the lingual arch, you will have a lingually applied force to displace the tooth buccally. So that will bring the teeth into alignment using this kind of active application of force from the lingual side. The amount of activation is determined during the simulation set up by the activation force system. So you have to first determine by how much the displacement should be. So as you can see here in this picture, there is no contact point displacement between the teeth. So in the simulation phase, this orthodontic he wants us to displace the two molars with this amount. So these are the directional forces bilateral. So when he inserts this lingual arch, he will put in its active form by compressing it. He will insert it into the attached lingual attachment here. So when it is inserted, as you can see here in this next picture, you will see a small dotted red lines being displaced. Means there is contact point displacement, which means there is expansion of the two molars or buccal movement of the two molars on both sides. So in such cases, without any further side effect, you will receive a buccally applied force from the lingual aspect. And these two forces, they will counteract with each other. So there will not be further displacement of the dentitions with the two molars in the transverse, in the anterior posterior segment. If an idle arch was used to posterior and in the almost part of the brackets for the expansion, and correct force would be produced. So the couple would rotate the molars mesially. So instead of angulating it like in the first picture here, if you see, you simply put it parallelly to the in the simulation phase, the effect is somewhat unwanted. So there will be not buccal displacement of the whole molar as a unit. There will be some kind of rotation. Like you can see the contact point displacement. So there will be mesial out and distal in rotation of the two molars if you apply the force in a parallel fashion, like you see in this picture. So this is what we have been saying. So sometimes even you may need to constrict the arch rather than expanding. So this is a simulation phase. This is the actual position of it is, and the orthodontist wants to bring this into the lingual position here. So when you insert this lingual arch, you will bring this lingual arch more into the attachment unit. So it will have attractive force, which will bring the molars inside or inward. In the process, you will have a constricted or a narrowed arch, which you need it for this particular case. So as you can see, still there is a contact point displacement showing you there is a lingual in movement of the two molars on the side. So similarly, testing the placement, you could do so many miracles in the lingual arch. And this is a very good advantage of using this lingual arches as an accessory component. And the other one is in the case of unilateral expansion, means using one segment as an anchor unit and the other segment as an active component. You can apply force to one side, which is asymmetric force application. So you could receive a more strong anchorage from one side to displace a single tooth on one side. So that's a sort of asymmetric force application or asymmetric expansion. So I think we have reached a conclusion of our today webinar. And in conclusion, rubber elastics and polyurethane power chain modules and such accessories are an integral part of day-to-day orthodontic consumables. And an orthodontist should have a good understanding of how these materials behave in oral environment and their force decay pattern values. So much of the care is needed in their storage and instruction of use. So like we discussed in the whole process, in order to have an effective orthodontic treatment using these auxiliaries or additional accessory components together with a conventional brace, you have to have a sort of insight or understanding of their basic biomechanics. So I hope this webinar will give a highlight, because it's a drop from the ocean. So many things have to be discussed, and in-depth understanding is required, but as much as possible, I am trying to highlight you what is meant by intraoral auxiliaries and how we frequently use and how we should use them with caution, without avoiding some unwanted side effects. So thank you for your attention, and for those of you who have been following me.